So this will be more of a emergency and a critical care part of a trauma care. So first is general principle all of us know, which has been discussed before. Basically, we have to, the crux is you have to be rapid, accurate, and you have to keep assessing the physiological parameters of patients who come across as a polytrauma, and a teamwork. Now, in trauma, all of us know that a death happens in a by trimodal pattern. Okay, the early death, the most highest incident of death is in early 24 hours, which is most 50% of death happens. The second one is after a week time, and the later stage of the few weeks, which are the various causes of death in that state is like sepsis, DVT, etc. So that is one thing we all want to prevent. We have already formed the team, which we discussed before, and team leader is what is the main important person who drives the show during the trauma resuscitation. What are we learning in this topic today? We would be coming across a case, and we will go through few important areas where a decision making is more important, and it should be in some kind of evidence based. So now let's go to first case. If you have a 74-year-old male who's diabetic, hypertensive, on medical management, is having no allergies, and he's come to your ER with a road traffic accident. On evaluation by a bystander, he was hit by a four-wheeler while he was crossing the road, and bystander immediately attended him, and he observed bleeding from head and scalp. He also noted a bruises on the thigh, abdomen, and umbilicus, and head and neck area, and left side of his chest. So here is, does this patient have a polytrauma? Can anyone say? Yes. So what is polytrauma? Now, there is many definitions have evolved over a period of time, and the Berlin definition is what we follow, which is in 2014, which indicates that you should have a significant injury of 3 or more points or 2 or more body regions with one or more variables from physiological parameters like age, conscious GCS, hypotension, coagulopathy, and metabolic component like acidosis. So this is the standard definition what we follow for polytrauma. Next is, now all of us have this definition. I think our patient fits in this definition, except we don't know our physiological parameters of this patient. But if you can see, he is involved more than 3. Now, to support your definition, you should also follow the scoring system. Scoring systems are there. Well, there are many scoring systems, but few of them are validated, excluding their limitations as well. And abbreviation injury score and injury severity score, both are like continuation of each other. And these are the two scoring systems which we follow usually while defining a polytrauma patient. Now coming to a second case scenario. So when you get a history, you need to classify your patient whether it is a solid organ injury or it's a polytrauma. And you have to involve these injury severity scores or scoring system to identify what type of severity it is and prognostication of the patient and how seriously you have to attend this patient. Now you have second case scenario. You have a 36 years male brought to the casualty with history of fall from bike, and he's unconscious for last 10 minutes. Now he's conscious but oriented with a heart rate of 110. He's tachycardic, blood pressures are normal, he's saturating well on the room air, he's able to move all 4 limbs but he was unconscious for 10 minutes back. Okay. Now on examination, he has neck pain when we asked him to move the neck by the side. Now, what are the common problems you come across in this patient? So how do you approach this patient? How do you approach this patient who has normal GCS? Quick one-liner. A patient who has 10 minutes loss of consciousness, but now he's normal, how will you approach?
We will defer it to the emergency medicine and see for the neck if there is a whiplash. There are
Yes, sir. Of course, but what I would take that point, and but since the patient is normal right now, this is the most of the patient comes in this category where you need to think once: should I discharge this patient from ER or should I further evaluate this patient? Now, what investigation you would do, and which subset of patient you would do some investigations if you come across such situation?
What is there in your mind, first thing which comes for the 10 minutes unconscious and then he will become now conscious? Would you think of a subdural or something?
Exactly. So we have to think about EDH or a subdural, which
pH is what we don't know.
extradural hematoma.
Huh?
Extradural hematoma.
Okay.
Yeah.
I think you'll have to talk in orthopedic terms. We are totally ignorant people. We only talk about augmentin and that's it.
Yeah. So we are suspecting a traumatic brain injury in this patient. Now, as far as what ATLS says, I will start with my initial survey, primary survey. We stabilize this patient. We look for any other complications and which we did not identify in primary survey. Now, in this patient, if you suspect a traumatic brain injury, what are the possible, because he had fallen down from a bike? Okay, so he could be having a traumatic brain injury which can involve brain contusion. He has a neck fracture. He can have a neck pain, so he can have a cervical fracture. He has fallen down from a vehicle, blunt chest injury, and of course he has a limb injuries. So lower limb injuries and a fracture can be a possibility. Now, once you classify the systemic problems, you also have to anticipate what complication can come across in these subsets of injuries. Now, what are the first basic thing what we do as per ATLS? We may look for the patency of the airway, look for restriction of cervical spine motion. Now, here is a dilemma. When you do ABC D in the trauma in a quick 10 minutes assessment, which can be easily done by asking the name of the patient and whether he is oriented to time, place, person. Now, if you ask a patient, like if this patient who was conscious, oriented, and obey in command, but he's still complaining of neck pain, will you put a collar to this patient or not? Yes or no? Yes, perfect. So as I was asking, with a parallel investigation, we have to also apply our adjuvant to these patients. Like you put monitors, you do fast scan, you do necessary blood sampling test, and you take quick ample history. Uh, Ample is which we discussed before, which includes allergy, medication, past pregnancy, last meal, and any events or any environmental injury in the past. Now, what do you do a specific specialized investigation in this group of patient? What we do usually at the bedside, so we'll do X-rays, trauma, cervical spine X-ray. We do a E-fast scan, and in case if you need to image this patient, CT scan will advise, provided if he is blunt trauma abdomen, blunt trauma chest. Now, question is whether you will do pan scan or will you do a individual scan? What do you practice in your day-to-day life? Will you do a systematic? Will you do organ-specific scans or will you do whole body scan? What do you practice? Anybody has any other opinion? So what is the advantage of whole body scan over doing an individual scan, and advantage of individual scan? So whole body scan, there has been good amount of meta-analysis literature that is number of, it's a time consuming. Second thing is the amount of radiation exposure happens in those scans are phenomenal. So the pragmatic practice is you individualize your care, do a specific scan which is required, and which are the most important, which is your life-threatening injury, and then you go for the follow-up scans. So that is what I would like to convey. Anyone has any other opinion on this?
On the trigger, and so again what you're, so it depends on the patient that is in front of you, and you should have a pan CT scan today with IV contrast doesn't take that long. as long as you've got that protocol in place, and there'll be specific patients that you put there. Obviously, under 16, try and avoid it. Pregnancy doesn't make a difference now. Second and third trimester doesn't make a difference. First,
either by a major spinal cord injury like a transaction, or it is a partial injury to the cord, and it presents with, as the little bit later in the time of injury, it can present with the spasticity. While in neurogenic shock, classical you see with the bradycardia and hypotension, and which is a vasodilatory type of shock which responds to the fluids. Now coming to the second and third issue which our patient had, he's fall from the height, he has lost 10 minutes of consciousness, now he has regained. Now we have suspected this patient as a traumatic brain injury. Now the management of traumatic brain injury is classified as per the grade of traumatic brain injury: mild, moderate, severe. Now severe is something where the mortality and the management matters a lot. When do you do a CT scan in a mild traumatic brain injury patient? Now, our patient was fitting in that category. So, if you have an open wound, depressed skull fracture, if you have a history of vomiting, if you have an elderly patient, if you had a history of anticoagulation, you need to do CT scan in this patient, even if his GCS is like above 12 to 15 between, and you think that there could be a suspicious of a traumatic brain injury. Now the goals here in traumatic brain injury management is usually airway, breathing, circulation. You have to prevent raise ICP, you have to start anti-edema measures, and look for decompressive craniotomy. Now, if you have a patient who has moderate to severe traumatic brain injury, the goal of the treatment is to prevent secondary brain injury. Now, what are the secondary brain injury can occur? I have mentioned it so we have to prevent hypoxia, hypotension, hypoglycemia. You have to do basic stuff which we do normally: head and elevation, intubation if patient is a borderline. Start a pharmacological treatment like anti-edema measures with hypertonic saline, hypoventilation, and last is decompressive craniotomy. In these patients, yeah. So this is the main thing in traumatic brain injury which we come across. In our patient, we also had a blunt chest injury, which can present with multiple complications like contusions, failed chest, thoracic hemorrhage, which sometimes you have subjected to resistive thoracotomy. So these patients have to be handled differently. Now coming to the important point, which I will go fast on that because we have discussed few of this point. Imaging we have discussed. Now how to resuscitate these patients. Now resuscitation in trauma is most important thing. And how do you normally start resuscitation in a trauma patient?
Mayur, you have to answer this.
Yeah.
You don't know.
So resuscitation is another, it is the crux of trauma care. Now we start with crystalloid, but what is the evidence for those things? Now there is big no for colloids, like albumin, which we sometimes is used in some centers. So you have to use crystalloids, then you have to avoid colloids, and principle of resuscitation in a trauma patient will depend on what are your goals. And goals are your variables like clinical parameters, laboratory tests, and imaging. Now you get different type of patients who are responder, who are non-responder. The fluids which we use normally are crystalloid. The choice of fluid is whether ringer lactates or cabilite. You avoid colloids. Now coming to the specific blood product transfusion, the principle used in trauma is 1:1:1. It has been studied well in various randomized control trial. We follow that at our center also, that we do the resuscitation as per the TAG monitoring, as per the coagulation parametering and hemodynamic variables. Now, coming to the transfusion of plasma platelet along with the RBCs. Now, what is the general principle for this? When do you transfuse these products? So basically, if you have a traumatic brain injury in your patient and you have a trauma-induced coagulopathy, there should be some guidance for you to decide on the transfusion of the blood products. But in general, you keep certain targets like platelets, coagulation parameters, and then take it from there about the decision of transfusion of blood products. Role of tranexamic acid, role of factor 7. There has been a well-supported evidence for these two. The CRASH 3 trial, which has helped us to survive most of the patient in a group of mild to moderate injury. Tranexamic acid, then factor 7, yes, in certain group of the patient, it is a low level of evidence, but it has helped to control the hemorrhage. Now, prothrombin complex concentrate are something which we used in our day-to-day life. When you see a patient who is having a trauma-induced coagulopathy, there is being supportive evidence for using PCC, FFP, and for patients who have low fibrinogen, who are coagulopathy, despite of using your usual measures, your usual blood products, when you push to a situation where coagulopathy is not settling or a bleeding is not stopping, you have to use prothrombin complex concentrate. These are the costly intervention, but it is right now being supported with evidence that use of these blood products has helped in reducing the need for blood transfusion. Though it has not improved the mortality or anything, but definitely it has reduced the need for blood transfusion and has improved the outcome for shorter interval. Coming to all you guys, like, because we are in a surgical team, damage control resuscitation. Now, damage control resuscitation is what we do. It has three important components which we need to know: permissive hypotension, hemostatic resuscitation, which we discussed just now, like transfusion of blood and blood products, and damage control surgery. Now, these are the three components. I will not go in details of this, but damage control surgery, the take-home message is damage control surgery should not be practiced in isolation, and it should be combined with damage control resuscitation and hemostatic resuscitation to get a good outcome. So you have to parallelly resuscitate this patient, prevent the lethal triad of trauma, and then go for damage control surgery. Now, timing of surgeries in a polytrauma patient, it hasn't been evolution from last 3 decades. Now, initially, the timing of surgeries were to fix the problem within 48 to 72 hours, monitor the hemodynamic parameters. But paradigm has shifted to now in early 20s or late 20s is do no harm and individualize your patient care. And you specialize individualized care to a trauma patient. There is no fixed role that I should operate the patient within 24 hours, I should fix this fracture within 72 hours. You have to individualize your patients. So that is the dictum currently we practice, and that is prompt, individualized and safe management principle of surgery in a polytrauma patient. Now, resuscitative thoracotomy, this is something which you may be called for or you may be a part of it. So, resuscitative thoracotomy is a temporizing measure that allows direct control of hemorrhage from exsanguinating thoracic injuries or a decompression of cardiac tamponade, and allows control of aorta to limit the bleeding from infradiaphragmatic injuries to facilitate the resuscitation. Now, this is something you have done in a few classical injuries. One is penetrating and blunt injuries, abdominal injuries. What do you do here? You do damage control. You have to you do pericardiotomy, you do aortic cross-clamping, you have to sometimes do open cardiac massage or internal defibrillation, and ultimately control the hemorrhage. And sometimes you can prevent air embolism while you go for a resuscitative thoracotomy. So in general, what I wanted to brief from my talk is apart from your basic crux of ATLS, individualize the patient care, practice evidence-based, and use certain latest evidence about the blood and blood transfusion, because the mortality is straight away associated with number of intervention we do with this trauma patient. Thank you.